Start the
Are you
recording. We are.
Now the recording's in progress.
We-
Okay,
yep,
we're
you-
here.
We are
We have
here.
a quorum. And we're just going to get right into it. Do we have any changes to the agenda?
I don't.
No changes to the agenda. I need a motion for approval of the agenda.
So moved.
Second. And a second in favor. Aye. Just put your hands up if you're voting online, just that way we don't have to unmute to vote. We're gonna try to fly through this. So I'm gonna say that we have a approval of the agenda. Now on to previous minutes. I'd like to have any corrections to the previous minutes or a motion to approve.
Approve.
I've got a motion from Linda and a second from somebody.
Second.
From Cory, thank you. And all in favor? Aye,
Aye.
thank you. Okay. So now next step here is welcome to new board members. And I'm gonna hand that to Jordana, so in case I missed someone, but I see these new faces we've been excited to have on the board, so go ahead.
Absolutely. So only one new board member this meeting. So we want to welcome Susan Merle, who is going to be the primary board member for Snowmass Village. And so Susan, would you want to introduce yourself and just tell us a little bit about yourself?
Sure. I am a new Snowmass Village Town Council member. I've been in the Valley for 30 years plus. I'm a CPA. My family business is Merle LLP. And I'm excited to join the Board of Health.
Welcome, thank you.
Thanks.
I see Krista has just come on as well. Hi, Krista. Liz Stark is there. We said hi earlier. I don't know if you can hear us, Liz. You can. Okay, great. Well, welcome, Susan. And we're going to go to public comment. If we have anybody in the room who would like to make a public comment. I don't see anybody coming up, and you're going to have to tell me if there's anyone online who'd like to comment. And my technique on that would be just to speak up, so identify yourself and we'll let you in. Not a lot of controversy lately, so I don't expect a lot of. Yeah. Oh, you can tell after today. Yeah. Okay, I'm gonna close the public comment now. If somebody's out there with a burning question, I want them to contact us though while we're here. As the chair, I can, at my discretion, invite public comment if I think we need to, but we're gonna move on. Next, Logan Hood is here from Community Health Services. And come on up, Logan. Good to meet you earlier and welcome.
Hey, thanks for having me, everyone.
Glad you're here in person.
Yeah, wasn't too. All right.
Okay, go ahead.
Well, good. That's really, thank you for organizing that for me, because I also put it in here. Good afternoon, everyone. I'm Logan Hood. I'm the Executive Director of Community Health Services. We're based at the Health and Human Service Building up just across from the hospital. Thank you for having me as a guest today. Today, I was just asked to just present what community health does for those who might not know that, or give a brief history and some data from the last year that we could gather, and kind of take you through a few goals and strategies that we've been working on. We're still in the process of finishing a strategic plan and some EDI goals and things, but I could pull out some things that I was happy to share today with you because we are still in the process. So just full disclosure there. Community Health Services is a private 501c3 nonprofit organization.
And Logan, can I
Yeah.
just give another little bit
Yeah.
of background
Yes.
why we asked
Sure.
you
Yes,
to be
please.
able to present here today?
Yeah.
I think board members in the past have continued to bring up the relationship between public
Mhm.
health and community health services.
Yeah.
And for many of us who can remember when Community Health Services served as the public health agency in
Yeah.
Pitkin County up until 2017,
Mhm.
when the county formed the public health department.
Right.
And so since then, even up until that transition
Mhm.
and all of the efforts that went into doing an evaluation to know that that was the best structure to move forward. And since
Yeah.
we really do work closely together, and the
Mhm.
way, you'll see when Logan talks about what community health services does, they provide those hands-on public health nursing services along with some other services.
Mhm.
Whereas our public health department, because we have this great resource in our community, we don't employ any nurses within the public health department, and all of that public health nursing happens with community health services.
Thank
Thank
you.
you for that.
And now I'll give you your next slide.
And I'll just do this.
And there's one more connection.
Come on. Do we need you on this?
Yeah.
Come here closer to a microphone.
Oh,
Dr.
okay.
Levin.
No, I just wanted to mention one more connection, that as the county medical officer, I have, part of my job description in 2013 when I started was to be a member of the board of community health services. So I've proudly served on that since then.
Yeah.
And has been a really wonderful connection with public health and
Mhm.
kind of a liaison, and has linked community health services, as you'll hear more
Yeah.
from Logan.
Great, thank you.
Thanks for that introduction, Kim.
Now, after 5 years, it's all starting to come together.
Is it?
Yeah.
Well, believe it or not, Greg, we're over 50 years old as an established clinic.
Oh,
And
I know
so
that.
I will take you into our history and background. Quite the history.
So is it, so the history's right in front of us.
Yeah.
I'll let you.
Yeah,
run through
I'll
it.
take
I
us
don't
through
wanna
it.
jump ahead.
No, and interrupt and ask questions at any time. I'm happy to answer them. So we were established in 1971. May 1st was when we established our nonprofit status. We were known as the Aspen Valley Visiting Nurses Association, AVVNA. We had our first clinic was on Spring in Maine, and it's still kind of structure is still there. It's just remodeled into a really nice home in downtown Aspen. It was really in response, based on the history that I could find, it was in response to Aspen losing their public health nurse. I don't know really where that was, if that was at the hospital or anything like that, but I just knew that coming off of the Touchstone Clinic as well was in some of the research at the time, which was really focused on mental health. So we were really just a small group of home visiting nurses. We were going into the homes, providing child well checks. We were doing parenting classes. We were doing vaccinations actually, and some senior care homebound folks. We were going into the homes and providing them resources. In the mid-70s, we became a Title X clinic, which is a federally funded program established by Public Health Service Act. It's through the CDPHE, and it's ensuring all women have access to affordable reproductive health, like annual exams, birth control, STI, and HIV testing and treatment. We're still a Title X. We're one of 80 clinics in the state that's still a Title X clinic. Since they started early 70s, we've also been alongside them, and it's a great partnership. In the 80s, after about 10 years, we changed our name to Community Health, VNA. Couldn't drop that full name, but it became Community Health Services, and added a prenatal program really to respond to the high rates of women showing up to the ER without any prenatal care. And there was a big boom of newborn admissions at the hospital in the late 70s, early 80s, was up 85%. Maybe Linda could attest to that. In the 2000s, when the Affordable Care Act passed, we started accepting insurance. Previous to that, we were just doing a sliding fee scale, self-pay. We weren't taking insurance. Medicaid wasn't part of it. So we added those options to provide folks access who did have insurance or Medicaid. We then, in 2009, formally contracted with Pickens County for the provision of public health services as mandated by the 2009 Colorado Public Health Act, which was, to Jordana's point, really acting as the public health agency. We added WIC, Women, Infants, and Children Services, and we were leading some disease containment strategies at the time. In 2016, when that started, in 2017, when the Public Health Department created its own department and its own Board of Health, we remained that clinical arm. And we then, designed our programs to be through contracts, reimbursable contracts with Pickens County. We also work with Garfield County and Eagle County to provide our other programs. But right now, and it continues to this day, we contract with immunizations, tuberculosis, and family planning. In 2018, I think it's important to share, we absorbed a nonprofit that was going to close and has been a big part of what we do to this day. We absorbed the Aspen to Parachute Dental Health Alliance, which continues to provide oral health services to students, prenatals, and seniors. I'll give you some more data points, but we typically serve anywhere between 13 to 2,300 folks by getting them oral screenings, hygiene, and some other things like fluoride and supplies and education. And we continue to do that. And that crosses over Pick and Eagle and Garfield. So we're doing a lot of pre-K and a lot of kindergarten, and then elementary, all the way up to seniors and prenatal. So that's our target population. Next
Wow,
slide.
a lot of change in 50 years.
Yes, yeah,
I remember the visiting nurses, and I was trying to think, there are probably still a few in the valley, Linda may know.
there
Who
are.
would be kind of fun to meet. to
Yeah,
talk about their
in some of the
business.
research, like, yeah, that some came to the surface who are still in Colorado or in the Valley, a few. Our mission as community health services is to promote health through the delivery of high quality, affordable preventive health services for everyone in the community. So we really, our purpose is to provide access to affordable preventive health services. We're not primary care. These are preventive services. And it's essential to the well-being of medically underserved residents and visitors, but also for the overall community. Our values, you can see here, equity, health, and accessibility. We're still working through these values and some of our visioning through our strategic planning right now, but I wanted to share these with you because I think they what ground us in the work we do. So, thank you. I just wanted to showcase our programs and kind of put them in buckets for you, what we're doing currently. And primarily, like I said, about 40% of who we see is through our family planning Title X reproductive health program. So that includes annual exams. We're doing birth control, long-acting reversible contraception. So someone could get an IUD for 12 to 15 years to really delay pregnancy, family planning. In that, we also do prenatal care. We account for about a quarter of the births at AVH that are Medicaid, that have nowhere else to get prenatal care in the Valley. The closest would be Avon. We also provide WIC nutrition and case management, monitoring, screening. We have a great partnership with All Valley Women's Care. So their providers actually come to the clinic and will see patients. They're both of our patients. And then we're able to really navigate their care through their prenatal and postnatal. Immunizations, this is one of our contracts with Pickens County Public Health. We provide infant, children, and adult vaccinations. COVID was a big part of what we did the last few years together. Flu, HPV. We do some travel vaccines. We're one of the only ones that really offer travel vaccines, like a lot of public health departments, they offer that. And VFC and 317. VFC is a federal program for all children who qualify by Medicaid and some other eligibility requirements, can receive free routine vaccination. Even if they have insurance and are considered, maybe their insurance doesn't cover routine vaccinations, they can still qualify for VFC. 317 is the adult portion of that who can receive access to routine and preventive vaccine. Oral health, I talked a little bit about that already. Out in the wake of the pandemic, we developed a teleoral health program, which has seen some real traction in the state, wanting us to scale it for an accessible way to talk with a dentist or a hygienist about oral health if they can't get into a dentist or need restorative, and want to get some options. But also we're doing that with a lot of families who, when the schools were closed, we couldn't actually see them in person. We also have a telehealth for our family planning program we just added. We do part of the reproductive health and Title X is our sexually transmitted infections. So we screen for gonorrhea, chlamydia, HIV. We are a site for monkeypox when that was part of needing a site here locally. And we also do things like provide PrEP and EPT. If you have questions about all those, I can go through that. And then health promotion and disease prevention partnership. Right now, part of one of our contracts is tuberculosis. So we are folks who are uninsured and don't have a provider. We can screen them and treat them. And so that's something where, when cases come up, you know, we work through that together with public health. And then rabies, that's another one. We actually had quite a bit of rabies this last year, a lot of bats and other rodents. So sometimes we'll see folks coming through town who maybe need a second dose. It's a 3-dose series, depending on where they are. And so we might be able to treat their 2 doses to finish out their series. And then cancer prevention and early detection. This is another program that's really unique to our clinic. We provide women with free cervical and breast cancer screenings, and they're able to go to Aspen Valley Hospital to get mammograms, biopsies, ultrasounds, and we navigate their care if they are diagnosed, or even just navigating them getting into their mammogram. So we're able to screen them at their appointment and then get them into this really early prevention for cancer. And so that's something also through the CDPHE that we've been working with as a partner program for years. Next slide.
Yes. Something nice, really jumped too many.
I think that's the next one, yeah. I thought it was just important. I have notes below if you want to look at all the details. I'll give them to you here, but just to look at where our income streams are. You know, a lot of our clinic is a pass-through. So not only do we receive grants, but we are passing through funds. We're kind of the entry point. So you'll see, I wanted to show expenses. I broke it down, regional, government, Picken County, program fees, the city of Aspen, donors and other grants. So Picken County is, let's see, where am I here? Let's see, Picken County provides, including the Healthy Community Fund and the contracts, about 23% of our overall income. Regional government, so this would include the town of Snowmass Village, Eagle and Garfield counties, and their public health departments that support our programs that serve those clients from those areas, at 13%. Program fees, so our payers are Medicaid, Medicare, that's just about 15%. And some donations in there and some other grants that kind of come in. City of Aspen's 5%, donations is about 6%, and other foundations or other grants is about 5%.
Can I ask just how,
Yeah.
how are donations, are these just?
Individual.
donors Who just appear, you're not
Individual.
soliciting donations, but people might come and offer a donation. of-
Well, that's a good question. So we do have a little box up front at the checkout desk that someone could leave a donation. That's about $2,000 a year of folks that I'll talk about how income comes in from or discounts to our clients and how this income coming in pays for their services based on their income. And then also, yeah, individual solicitations and donations and board giving is also in there.
Okay, great. And that's that you're 6% of the total, and I
Mhm.
don't know what the total is for income. But
Oh, I'm sorry. It's in the notes underneath the slide. It's 1.1 is our budget.
okay, got it. Great.
And that's a balanced budget in and out. Expenses, primarily payroll to actually do the nursing services is payroll and benefits is 72% of our overall expenses. Program services and supplies that counts birth control, vaccines, medical equipment to do the actual exams and things like that. And then G&A is 10%. You kind of see how we're broken out there. It's a little busy.
Picken County donates we have in-kind.
Yes, we
donation
do.
of the
We do.
facility, right?
Yep, we do. So our clinic, based in Health and Human Services, our space is in kind.
Is
Yes.
that reflected on that?
Yes.
income, or is it
Part of the
official?
Picken
Right.
County. Yep, it sure is.
Great, thank you.
Yeah. So here, I wanted to just give you a summary of the 2022's, unduplicated clients versus visits over the years. You can kind of see 2020 being a little lower for reasons of COVID. But also, what's not reflected here is our telehealth during that time. These are just strictly in the clinic, and or maybe some mobile clinics, considering flu and COVID and things like that. The number for 2022, I think, attributes to we did have a change in our electronic health record. We've lost a little bit of data, so this is a conservative number, what we can extract. It was back in the falls of last year, so the best that we could do. So I think it could be a little more, but we also had some staff turnover, some low staffing shortage, like so many of
Is
us.
the, you said telehealth is not included in those numbers?
It's not, that's a
Right. Do
separate.
you have any data on, has it increased or has it, is it?
Yeah, so the tele-oral health through our dental program has increased when we initiated it in 2020. Each year it's grown and I can definitely get that number for you. I don't have it off the top of my head, but just getting the word out and offering that in the schools again as an option in addition to screening them like in person, that's another way to reach people. But really, we were just going back to past clients and reaching out to our networks to say this is an option since we can't get into the schools, which is so much of those numbers. That's probably
I
why.
was just thinking, I could imagine telehealth becoming a bigger component going forward.
It's definitely growing and it is the way of the future. And needs to be for accessibility primarily for that reason. And saving a trip, and parking and all that stuff. So by county, this is just 2022. It's a little bit higher this year. 68% was Picken County clients. 20% Eagle, Western Eagle, 11 Garfield, and 1 from other, which could be considered other visitors, things like that. Let's see, I think we can go into the
It's
next
really a
slide.
local valley service.
Definitely, definitely. This is, a slide that I'll try to take you through. Bear with me because it's kind of complicated. Wanted to fit it all on one thing. 93% of our clients in our family planning program are eligible for a slide, which means that they don't have insurance. They income eligible. We base it on our guidelines for the federal poverty level. So up to 250% of the federal poverty level. We don't ask for documentation. They don't have to prove income. We just ask how many's in your family, what's your household income? You need help? We'll help you. So of the family planning clients, which is about 40% of our overall clientele, you can see about 31% of them paid $0 for their services. And that, includes their annual exams, their mammograms, their cervical screenings, their birth control. And then we had another 62 of those folks 62% of those folks who fell on the slide at some point. The slide is really important because it provides an entry point for someone without insurance or even a high deductible or no insurance at all, or even Medicaid to outside of those opportunities to still be seen and get quality care. Of the immunizations I wanted to break out because I think it's really important, just trending into this last year, seeing COVID being a lot less just because the Vax bus was here. It really did play a role because that number was so much more higher the year before. I think it was like in the thousands. I mean, we did like 8,000 vaccines. But for this year, I thought it was interesting and to really focus in on the flu and the VFC, which is the federally free program for vaccines for kids and adults. And then the top one was travel. So that's about 9–10%. And that's just additional, that's an income stream too for travel vaccines because insurance doesn't typically cover yellow fever or typhoid or anything like that. Let's see what I was going to say about
If anybody
that.
has a question, they
Yeah.
can't see you, but you can.
Yes,
speak
please.
up.
I'm going through it fast.
Yeah, good job.
Next slide.
Sure. Some of the goals we're working on, which I think is really important to focus on where we want to go, is providing quality outcomes for our patients. And that means that they can reach their optimal health for themselves. Providing access, affordability, delivering services for all, not just including medically underserved is the word we're trying to kind of coin and figure out to how to say that, but to provide folks with insurance, STI testing and birth control access if they can't get into their primary or don't have a primary. And that's the thing about community health. We really want to focus on getting someone a dental home. We want to get someone focused into having a primary care for overall other health opportunities. We want to make sure that we continue to achieve highly satisfied patients and families. I think from our client feedback, we hear time and time again, I love coming here, how I have my experience, how I'm treated, how I'm heard. Many of our staff are bilingual and bicultural, and it is about 50% of our population is identified as Spanish speaking as their first language. We want to ensure that we're financially stable and sustaining this. You can see a lot of different pockets to fund these programs. That's important to us, and be responsive to the evolving community needs. Like you saw in our history, evolving into adding a prenatal or taking on the dental when no one else was going to house it. And I think that's where we're trying to find out, what is our role? What could we take on? What do we need to consider? Is that our place, or do we just be a collaborator or an advisor or something? Because sometimes things end up being a catch-all. And so we don't want that to happen. We want to be mindful and really grounded in our mission and the community we serve. And then being diverse, equitable, and inclusive. I mentioned we're working through a lot of that internally and at our board level in the future. And then understanding how we can eliminate any disparities to keep people for a healthy life. We want to make sure we're aware of those disparities and what they're going through. Next slide. Thank you. Some of the strategies to consider out of this was looking at our stakeholders who did respond and interviews that we had to understand what are things that maybe we're not looking at, but that we can consider looking at. And I think it's really expanding awareness and clarity of CH's role and function. I took us through the history because I think that when all of that changed years ago, I think it can be a little like, well, who is that? And is that public health? And so I think, yes, we're aligned in some things, we're collaborators, we work together in certain things, but we get calls for environmental health purposes. I think it's just clarifying who we are and why you would come to us and for what reasons. Looking more into the service population, we could do more in the schools. There isn't a school-based health center in the Upper Valley, and we are doing that through our family planning program and some outreach in the schools for access to birth control and other options, and just counseling and STIs and HPV vaccines for prevention. Looking at the Latinx and the BIPOC communities and connecting with them who are leaders in those communities as well, to be working together and listening. And you can see some of the responses: individuals experiencing homelessness, the senior community, and what came up was a homebound community, and home visits that came back again from where we were years ago. And that came out of getting calls during really the heightened of COVID. Could you come to my house and give me a vaccine? I can't, I'm fearful, or can't get out, or things like that. And then just some of these other things, looking at improving our accessibility. Do we need to stay open longer? Do we need to be on weekends? All that kind of a thing. Really just looking at all of it and in a transparent way. Something else we've talked a lot about in some of the work, but things that surfaced is, including, we do our integration with some of the programs we do now within each other, like dental for prenatal or vaccine for our family planning client. But could we look at behavioral? Could we look at other medical, child wellness checks? I don't know. We've kind of played around with that. And that's why this time is really great. We're talking through it post-COVID. And then exploring continuum of coordination to align or maybe merge with a complementary organization that came up in the past. What does that look like? So those are all things on the table. And then, like any best practice, looking at unduplicating any services. If there is duplication, where is that? Are we the only ones doing it? How can we better serve or support each other? And then, folks who are coming to us, could they be going to a primary care, or could they have established care somewhere else other than coming through to us? That's it. I thought I had a couple more slides, but room for questions. Lots of questions. That was a lot. I know. Thanks.
Clearly.
I hope I met my time.
Questions. I've got a couple of questions, but I want to see who else is out there who might have a question before I launch in. Dr. Kirk, go ahead. Oh, you're giving me permission. Thank you. I've received a couple comments. People asking, well, how do you decide the relationship with the medical community? For instance, I'm at an age now where I've been asked at the pharmacy, like, have you had your Shivrix, your shingles booster, whatever it is.
Yeah, your shingles.
And I'm just wondering, it seems like everybody in the community is being asked this. Is that something community health would take on, or is it well served enough that you wouldn't see a need to, or would you offer it to the segment of the population where you primarily serve? That's the first question. Second one was about wondering if there's ever been a screening for hypoxia or sleep apnea issues. And it seems ubiquitous. I'm not sure how ubiquitous, but it occurs to me sometimes that the entire community is hypoxic. That's why we think we're special, right? So just wondering if something is as possibly spread out across the entire community through an entire demographic, is that something community health addresses, and how would they address it? Those are 2 questions.
Yeah, to the first question, I think it's important to know where your providers are. Like we said, we're preventive health. We really want folks to have a primary care. If they don't, we do take Medicare. And we have 317 vaccines available if Medicare Part B doesn't cover it. So things like that. One of the target populations was senior. We do a lot of senior dental. That's a place with Medicare that barely covers minimal prevention. So we really fill in the gaps there for maybe insurers or payers that would not otherwise. And unfortunately, the senior population is overlooked a lot. Now for things like sleep apnea or other things, would that be something a primary care wouldn't be doing? Where that's questions we need to be asking our community and evolving with community needs. If there is enough of that, is it a public health concern? Is it going to prevent something else down the line? I think that's just adding something would really, we're a small clinic, but really looking at, is that a primary focus for our community, and how do we get to that and understand what that is? Is it a public? I think a lot of what we're looking at is prevention through the lens of CDPHE, maternal health, family planning, access to reproductive health. So I don't know where that would sit, but it's not off the table if it's a community issue. I think it's
Can I
something.
comment on that too?
Yeah.
This is Krista Giesel. I am a primary care doctor. And Greg, I think that the hypoxia in particular, that's a really complex issue that there can be a lot of different pathophysiology and mechanisms that can lead to that. And so I definitely think that is addressed by primary care clinics. And I think that's what she said, is, everybody really should have a primary care doctor. Shingrix is definitely pushed by your primary care doctors. And then I think that, again, we as primary care doctors have this relationship with community health as well, where we kind of divide and conquer, but there's kind of 2 different things. And I think things that become more medically complex, where it's not just clear that, like, here's a very quick screening test, here's a very easy treatment. Those really need to go back to primary care, is my personal opinion.
Great. Okay. Thank you for that. Other questions? Comment, Dr. Kirk.
First, let me thank you for a very thorough description of your department. I essentially have 2 questions. First, your staff, how many full-time staff, and how many of those full-time staff are healthcare providers? And then I think you have part-time staff where you interact with the OB at the hospital and that kind of thing. The second deals with an area of my personal interest, toxicology. Maddie Sullivan runs the Western Harm Reduction Group. Do you interact with her? Does she interact more with Jordana? And there's a new grant coming out, federal grant, I think $1 million for the Western Slope on the opioid settlement. How is that going to be handled? And we have drug problems in the community. How is that handled? So 2 questions. Thank you.
I'll start with the staff. I could do that, and it was on my notes, excuse me, on the PowerPoint. We have a FTE of 9.4. We have a total staff of 14. Of that, 10 are clinical, but they are not an MD. The highest level is a certified nurse midwife. But we partner and have a physician supervisor, Mindy Nagel. And then we work with Kim Levin for some of our immunization oversight. So we really have to outsource that. I think it came down to a cost issue, having like a physician on site and being, I think, community funded. That was off the table for a long time. We have 1 part-time intern, and we have 12 volunteer board members. And of that board, we have 6 committees. So non-clinical is the admin or the navigators, things like that. Of the clinical folks, we have 1, 2, 4 that are bilingual, bicultural, that are direct patient care, provide 5. sorry. And work directly with clients through their exams. But we have to outsource and have medical oversight and a supervisor, part of our Title X requirements. So hopefully that answers your question. At the Health and Human Service Building, there is recovery resources and drug testing. So really the entry point, I think, is for Health and Human Services. We're located there. If we have any concerns for our client in some of our, social determinants of health, or some of those screenings that go on prior to an exam, for instance, if that comes up, I mean, we do a lot of referrals and support, but offering, we have Narcans available if we had to have that on site, but we're really kind of, again, that pass through. And if there was someone with that, we would go to the direct source.
And with the settlement dollars, that's
Yeah.
where public health is at the table, as
Okay.
well as, I think Steve Child is the commissioner who participates in the regional group that decides of that settlement money, how is that going to get spent? And so currently there's a proposal out there, whereas you might have to help me. It's looking for 3 different components. One is for someone to develop a prevention awareness campaign, anti-stigma campaign, opioid data dashboard, and harm reduction services. Larissa has been running point on this work. And so we are there at the table. And then Picken County, the commissioners had the opportunity to opt in to receiving additional funding, or they could opt out or opt in, and either give more money to the regional work or have it come down locally. They opted to receive some additional funds locally. And so we will be using that funding in we received it last year in 2022, about $6,000. We'll be spending that on on promoting that educational anti-stigma campaign in the community. So that is to come.
And partnering with the city of Aspen to.
Yes, the city of Aspen has received about the same amount of money, and that is what was decided to do with their funds as well. So we'll be helping to spend those.
Yay.
What years will that be running?
18 years. Over 18 years,
Wonderful.
yeah.
Great.
Thank you for helping with the question of the visiting doctors from Bariloche,
You're welcome.
which we had.
Yeah, you're welcome. Happy to help. And that's the thing, I think if Jordana comes up with something and, in our collaboration partnership, it may be, hey, would you consider this? I always just have to think about staff capacity and our current programs to keep up with. So, if it comes up and there's an opportunity to work together, that's always on the table. For sure, with any community that we serve, with Eagle County and Garfield as well.
I have a question just about communications.
Yeah.
You don't have a big PR budget. Do you rely on the county communications department? Like, how do you?
Gosh, I wish, yeah,
You're
that's a
trying to
great
get the
question.
word out. How do you do it? And who does that?
It's very limited. Yeah, we really don't have a marketing budget. Part of that outcome assessment was we need to get the word out. How do we do that? But are we duplicating that through Flu, for instance? There's a big campaign and dollars behind, and you have a department who does a really great job. Some of our programs through the CDPHE, they give us things that we could put in the newspapers and things like that, but not a lot. I mean, I will say primarily we're word of mouth. And being in the community for as long as we have, with the providers that have been with us as long as they have, we have a real trust. And we're anchored in the community enough that, and just the partners and other primaries and other folks that refer to us as well.
It seems that if CDPHE is giving you press releases to disseminate, that's easy, but that's, once again, that's CDPHE. They're
Yeah,
not
exactly.
at this elevation,
At this level,
not
yeah.
Particularly high country
Exactly.
specific, so.
Yeah,
If there's a gap there, it'd be good to know about it.
yeah.
Between the two of
We
you.
could do more.
Excuse me, I've suggested op-eds in the local newspapers.
Uh-huh,
Help promote your program that way.
Yeah,
like
yeah.
Once every month or two.
uh-huh, and, yeah,
Get one of our board members to help.
I would love that. I'm gonna put you on that. You be prepared. I think something's coming. Yeah,
Yeah, you're in a position to be delegating it to others, right? So-
yeah, especially, Picken County does have a lot of resources and we're one of just many that, are doing great things in the community, but could use some support in that department for sure. Just thinking off the top of my head right now, because
Well,
that's
we're
hard.
often, electeds are often called upon by various and groups we're part of to contribute to an op-ed. Often
Mhm.
it's, they'll say, hey, we'll provide you the talking points, you write the
Mhm.
letter, it's to make it
Right,
easier.
right,
obviously.
yeah.
That sort of thing, certainly something you can reach out.
Yeah.
Patty was on, well, maybe she's not here, you can delegate it to her. I'll tell
She's
her
there.
to-
She's not listening. No
Okay,
problem.
great, thank you for
Thank
coming.
you.
That was
Yeah,
really
I'm gonna
helpful.
stay and hang
we're-
out.
We're ahead of schedule. Are we ready
No.
to switch to the next event here?
Sure thing.
Okay, thanks, Logan.
Thank
Thanks for
you,
coming
of
in.
course.
Great
Yeah,
to
thanks
see
for
you.
having me, everyone.
And up in the docket is Dr. Levin with our respiratory disease update.
And Logan, thank you. It's so nice to see you here. And really, it is the essential clinical arm of public health in other communities and larger urban centers. It is in the public health department. And so these services are so important to our community.
It's great to learn about how the synergy. Thank you.
Yeah, it's interesting. Different communities arrange it differently. So this is how it's done here. All right. I am Carly today. And I use reading glasses and she doesn't. So anyway, so this is the respiratory update for stepping in for Carly. She did this first slide, which always looks a lot nicer than mine, but overall the picture is that we are in a much better position than we were in December when we met in December last. So the numbers are decreasing across the nation. They're decreasing in Colorado. Picken County is in the lowest category in the state. We're in a low plateau on our website. And as Carly had mentioned last time, XBB 1.5, which is now still the predominant strain, which is higher transmissibility, but not proving to be higher severity or increase in hospitalizations. If you look at that upper right graph, the kind of the lower dark blue, and that's only mentioned, it's from November 1st to now. So just over 3 months, it went from basically nothing to the predominant strain. And then the upper light green, which is BA5, went from the predominant strain to basically nothing. So just the very fast changing landscape, I think, is always important to look at. It's still happening. XBB 1.5 really started in the Northeast and spreading west rapidly. That bottom right graph is based on wastewater data. It's from the CDC. And it looks at all the wastewater sites across the nation. And it's looking at, is COVID increasing, decreasing, or staying the same? And the red is fastly increasing. Orange is increasing, but not as quickly. Yellow is staying the same, and blue is decreasing. So everything's happening in different communities, basically across the nation. It's still present in wastewater. And some communities increasing, some of them are decreasing. And then Carly wanted to remind everyone XBB 1.5 is of a different evolutionary line. So you're still susceptible if you've had something else recently. Of note, there's been a spike of cases due to some type of a data lag out of Mesa County. This affected the overall number in Colorado, but did not affect Picken County at all. And then in terms of the flu, there's been some flu B that's come up over the past 2 weeks. Flu A still is the vast majority, 99% of all the cases this winter so far. But if we've looked at other graphs, that flu B is often responsible for a second wave. And so we'll see if that happens. All right, next slide. So the CDPHE just launched a new combination respiratory viral web page yesterday. And I think this is a brand new graph, right? So this is the shift, as we were talking about before. We're now shifting away from just COVID and including all three. And this is the endemic picture. So this graph is interesting. It looks at admission rates, which is a little tricky, but since the beginning of December, the rates of hospital admissions for all three of these have steadily been declining, and they're down very low now. So this is all good news. Next slide. This is what I showed in, or maybe Carly showed in December. So the red is the current season. I think we were up at the peak in December and not knowing what was going to happen. And so this nosedive happened. And this is great news. Again, flu, this is predominantly, and this is all influenza associated hospitalizations. Compared to the previous years where it was flatlined in 2021. So the peak was really early, it was high, and then it went down. Not as high as the 2017, 2018 rate, but definitely peaked fairly high. And will there be a second peak of flu B to be announced later in the season? We'll see. Next slide. Okay, and this is, I just wanted to do all hospitalizations for COVID-19. As we know, data for COVID and flu is no longer completely accurate as we've moved away from PCR testing to home testing. So looking at hospitalizations really gives us a lot of information about what's going on. So currently we're at 182 currently hospitalized in the state of Colorado. This is a CDPHE graph. A year ago, we were over 1,000. This is 1,676. We peaked, I think it was like a year ago, but January 1st, maybe. So we're in a much better place, and this is much more of like an endemic looking picture at this point.
Could you do we have data on the uptake of flu vaccine? Is the flu shot helping? Did it help with the?
It has helped. Yes, it's shown to help. I don't have the data. It still works. It still works. And they've done the flu vaccine every year. They try to guess what the most popular strains are going to be for the next year. It's a little bit of a guessing game. Some years they get a little bit better, and I think it's done well this year.
Thank you.
That's a good question.
Thanks for interpreting my question attempt.
This is the new Pickens County Public Health website. Everything's been streamlined, which I really like. And if we look at the AVH hospital status is comfortable, we're moving away from using the matrix to just a streamlined approach. And I just wanted to mention that AVH has entered a phase of recovering from COVID. So masks are now optional in the hospital. They have resumed, they've opened the cafe to the community. So this is the first time since COVID that's happened. Pet therapy is resuming. They've resumed the pre-COVID visitation policy, which a lot of patients and families will be very happy about. Basically really opening up to pre-COVID type of situation. The only thing that is new, and I think improved, a silver lining from COVID, is that there still will be screening for symptoms. So if you have symptoms and you're not a patient and you're a visitor, please don't go into the hospital or don't go into any public place really without a mask, or if you're within the first 5 days of your symptoms. So there will be some increased screening just to keep everybody safe in the hospital, but it's opening up. So that's very exciting.
So the front desk will still be there and they'll take your temperature and ask
Nope.
you. They don't do any of that.
They're not going to be doing that anymore. Yeah, they're just asking you if you have symptoms to please, if you're greater than 5 days out, if it's necessary for you to come into the hospital, wear a mask. There should be masks there, or bring your own mask. But masking is optional in the hospital now. So there's a lot of staff and patients that are not wearing masks. There's a lot of people that are in the emergency department, where there's kind of much more of a high risk and a lot more flow of patients with symptoms. A lot of people staff are still wearing masks, especially in patients' rooms. So it's still happening. And I think it's just kind of at your own risk, and make good decisions.
I think the big announcement for me is that we have an affordable restaurant in Aspen.
The Castle Creek Cafe is open, and it's wonderful. Yeah, I was going to mention one more thing. I don't remember.
Gift shop is to be determined.
Oh, the gift shop it was planning to be reopened, but has not quite yet, but there will be plans in place for that as well. And for the volunteers to come back safely. So a lot's happening. If AVH is still basing the CDC level. We're at low right now, but if it were to get high again for COVID, there would be changes. So there's flexibility in this. This is where we are now, and hopefully stay in this position. So the next two graphs are from AVH from the lab. This is a little chaotic looking, but it is, I don't know if I showed this last time. This is from AVH lab data. And so I just thought it'd be interesting to look at. What's that?
Good art on the wall. Yeah.
Do you want me to, we could get that arranged for you. Yeah, put a nice black frame on it. and- Yeah, maybe put it in the art museum. Might, yeah.
Aspen's really too small of a sampling. You need a bigger community of numbers. What about AVH employees? Or any of them been sick recently?
There's definitely down, there's a couple out right now, but it's gone very far down. So things are looking a lot better in that as well.
Paxlovid prescribing.
Paxlovid prescribing, it's still being prescribed. You know, there's the Paxlovid rebound and there's a lot of interactions with other medications, so you have to qualify for it, but it is available at City Market Pharmacy. Yeah, and that's been streamlined as well. And it made it a lot easier. So, yeah, so just these last two graphs, the flu is in the blue. So that peaked at AVH in the middle of December, and then COVID is in the red. So that was a peak afterwards. And then the green is RSV kind of in the mix there, and all the other viruses in the yellow. So this basically reflects what happened at the state level, which I think is interesting. And then the next and last slide is, I just thought it'd be interesting to look at, since we started looking at this since since October 1st, what percentage of all of these tests were in each of these categories. And flu is the biggest overall, 36%, COVID 29%, RSV was 18%, and then all the bucket of all the others at 17%. So I just thought that was interesting to share. And that's the respiratory update.
Great,
Anyone
thank you.
have
If
other
you don't
questions?
mind, if you're still here, and Logan, before you leave, I don't know if you're gonna stick around for me, but I wanted to ask a question that I forgot to ask earlier. I read an article about the activist students at the high school in Durango are demanding that they be given Narcan to dispense as needed. And I'm just wondering, are we gonna have a conversation about that? And what is your take on it? Because I wonder, I don't think the kids in Aspen are as concerned about it as the kids in Durango are, maybe for good reasons, hopefully.
Mhm.
But I'm just wondering, has that come up? I wonder. if
It
I
is
should
a
have it.
question of perfect timing, because we're working on something right now. With Larissa's working on it, Robin Strecker at the nurse at the Aspen School District, and myself to have a standing order for it. So we're in the midst of making that happen for the school district, which is exciting. And so, yeah, I don't know if there's any more.
Would be available, or with
The what?
the test strips?
Yeah, we're public health working on the contract with CDP,
Mhm.
yeah, fentanyl test strips.
Okay.
So waiting the contract.
And that'll be included, yeah, when that
So
becomes
more
available.
to come on that.
More to come, but that's in the works. It's exciting. Narcan, as you know, saved a life. It reverses an opioid overdose, and it has a high safety profile, and to have it in the hands of every child and parent and teacher of someone who may be on opioids can be life-saving. And
Maybe in public buildings.
it's
like-
really easy to give, and the form that we're doing is the nasal form, so it's really easy. It's a squirt in. Very simple.
Patty has a comment.
Yeah, you know, I'm a big supporter of Narcan, but I just think we also need to keep in mind, in giving it to, say, students, to schools. I don't want kids to feel that they can say, oh, we can do these drugs because we all have Narcan on, at hand. So I think there needs to be an education process. This doesn't give you the permit to do drugs because you have somebody sitting next to you with Narcan, because I don't want kids to feel that safety net. I think that's important part of the education process.
Thank you.
Absolutely, Patty. Thank you for that comment. And there is training that the school nurse will be doing firsthand.
Great.
As
Dr.
a
Cook.
corollary of what Patty said, they've shown recently that one Narcan is not enough with fentanyl. You might take 2, 3, or 4. In fact, I've read up to 16 Narcans have been given in ED care. So
Yeah.
they shouldn't have an idea that this is the answer totally.
Absolutely. And so that is also written in the standing order that we're working on, that you repeat the doses every 2 to 3 minutes as needed. Again, it's a safe it's a safe drug, and you're right, some ERs have actually been depleted of the supply because some of the fentanyl that's being produced is so strong.
And at this point, I think really props to the school, to the school district for looking at this policy, and it's being done in a preventive way. I think Durango, they've had a number of overdoses already that they're trying to address how to safely have this available for students and staff. We're really looking at it in the preventive scope up here.
Yeah.
Thank you.
And it's also being given out in the ER for patients that get opioids now from the state program, that it's been provided in emergency departments across the state. So when someone gets an opioid prescription, if there's any concern or risk of addiction, they get a Narcan take-home pack too.
Yeah.
And that took a while to get initiated, and it's actually happening now, which is great.
I see Krista has her hand up. Still, are you still? Yep, okay. You're
Just back to the respiratory presentation. Are we still monitoring wastewater?
Yes.
Okay.
And we go back to the Picken County site. It's one of those categories is wastewater. It's one of the main ways that we can still monitor COVID is through wastewater. since
And
the
we'll
data-
the plan is to keep monitoring that.
Mhm.
I'll let
As far as
Kurt
I
talk.
know, it's you.
Go for it, Kurt.
So we're monitoring wastewater in Aspen, Snowmass Village, DeSalt. And then we have hopes that maybe Carbondale and or somebody like Redstone will join as well.
great.
Thanks.
Okay, is there more? Dr. Levin is,
I think I'm done with
you're done.
the respiratory
back
update.
later.
Yeah, I'll be back.
Okay, then we're going to go to the director's report. Jordana, first of all, if anybody has another comment or question, I just want to make sure I didn't leave anybody out. I don't see hands up or anything. So we're going to move on to the director's report, which will be including the meeting schedule for 2023, working agreements, review terms, Board of Health training requirements, staffing update.
That is it. So in our bylaws, we lay out that we go over our 2023 meeting schedule at the first meeting of the year. And so these are the dates that we have set for this year. You should all have calendar invites for these on your calendars. The plan is for Q1, which we're in right now, Q3 and Q4, to be the normal 1 to 3:30 meetings that will be hybrid. And then the plan right now is for May 11th to be an in-person retreat at the library, which would be just an in-person option. So if there are any issues with that come up, please let myself or Greg know. And Krista and Greg and I will be sitting down after this to really start hashing out that May 11th retreat. So if you've got any thoughts on that, please feel free to reach out as well.
Right, great. Yeah, this is our chance. We just came out of our VOCC retreat. It was a 2-day retreat, and I confess it's exhausting, but it's also, I come out thinking it was never long enough. And there's always a list of topics that we didn't get to. So if anybody has thoughts on retreat topics or something, the burning question that never comes up, please get a hold of us and talk to us about it. Try to fit it in.
And Greg, I'm so sorry to say that for the August meeting, I will be in Iceland and will be not able to attend the meeting.
You don't sound that sorry, Patty.
Sorry, guys.
He's not sorry.
It's also in our bylaws that we review the working agreements at the first meeting of the year. So I just wanted to put those up here for folks to be able to look through and think through. But I think this would be better served for our in-person retreat in May to really read. I don't think we've had an opportunity to revisit these in detail since we've first wrote them. So just to get your creative juices flowing about working agreements, that will be something that will be on the agenda for May.
Got it. And I have to say, I'm looking back at this, when we first formed this, I think I was the one who proposed the brevity is the soul of wit. Perhaps a bit whimsically, but honestly, it's great when people are succinct and prepared and able to get it out quickly. So I'm happy to leave it in there, but I thought since I was the one who inserted it originally, I thought it, you know, somebody might decide it's time to push it back or something, but I'm okay with that. And I think it's worked. I don't think we've stifled anybody's freedom of speech or need to discuss something in detail here, but I just thought I'd highlight that. Shakespeare.
I just wanted to cover that the terms for the Board of Health are 5-year terms. They're staggered, so half of our board terms are up in April of 2023. Greg, Patty, Linda, and Tom. And so I think everyone's aware of that. There is the option to extend your term. And so Charlotte will be reaching out from the Pickens County administration to see if you're interested in continuing on in another term. And if not, we will go back to the process for getting board members appointed. Training. So I know we've covered this in a couple different meetings, but wanted to open up the floor here because there is an annual Board of Health training that is required by Colorado statute to be done by members every year. We had about a 50% accomplishment rate in our Board of Health training last year. And so in reflecting on how we might be able to boost this up, I wanted to see what folks felt about either doing the training on your own time, or if that might be something that we should make time for during the retreat, where everyone can kind of do the training independently on a computer or a screen. And then you know that it's done and checked off for the year.
How long is the?
It's about an hour.
I feel like they made me do it twice this year too, Jordana.
You made up for those of us who didn't.
I was gonna say, can I get one first?
Yeah, can I have one of those? What do you think?
I was gonna, we probably shouldn't take an hour of our retreat time to do that. We should do it on our own.
I agree. I think I see nods of agreement from Liz and Krista and Susan. We don't need to take a vote on this.
No.
It seems as if anybody has an issue, let us know, but I think it'd be nice to keep the retreat for more topics, because who knows, you may be able to go, some people can get through it quicker, some are slower, who knows on. So let's try it. We can do that on our own.
All right, we will, we'll make that happen, and maybe have some time on the retreat to, kind of do a check-in or answer any questions or do something that's a little bit more engaging based off of the training. But I will continue to send information out on how you can do that on your own. So thank you for that feedback.
Great. Maybe we can provide incentives of some sort, you know, like a ski day with Jordana.
Now, you don't get to meet with me until you're all trained up.
You could learn in the gondola.
Open to
Door
ideas.
Door prizes, right, yeah. Okay, thank you. So we've solved that. Staffing updates.
And then just wanted to let everyone know that we do have 2 currently open positions. One is for a mental health data analyst, which is a term limited position, helping us do some of the care coordination, behavioral health, leadership work that we're doing in the community. That position is being interviewed in the next couple weeks. And we have 3 days left for any applications for the deputy director position, after which we'll do some interviews. And then also wanted to update the board that we will be coming to the Board of County Commissioners via a budget supplemental for a position that we requested be included in the budget this year. But we still didn't have any funding nailed down for it. So we have some better leads on funding streams that can support our communications and community engagement position. I think as we heard Logan talk about, there continues to be this big need in public health to get information out, in a culturally competent and language appropriate way in our community. And just continue and to start and continue building those relationships with a lot of our partners in the community. We've been able to make some strides during COVID because we have a position dedicated to that. And we really want to continue to have that capacity and build on it and make it serve our entire department, not just our COVID efforts. So that's a position that we're really grateful that the Board of Health supported, that the Board of County Commissioners sees the value, and that hopefully we can come forward with enough funding for that to become a permanent position in our department.
Question, is it possible a position like that could include looking for community health, or does it already, is that already part of the mix? Like, could Logan's need for communication be covered by that individual, or is that something to consider?
I think it would depend on which piece we're talking about. Logan and I have been talking about some different community engagement efforts, some potential health promotion efforts that we could work on together. These would be things that that position might work on with both departments. And then we've also gotten better, and I think there's still a ways to go in terms of streamlining the respiratory disease campaign work that happens, every fall, reminding folks about immunizations and hygiene and good practices around cold and flu season. And so those would all be pieces that this position would be able to expand to.
Great, thank you for that.
Anything else from folks on the line?
Questions, comments?
Okay. If we're good, Greg, I can move into the next section to talk about our public health areas of work. And so what we wanted to share today, being the first meeting of the quarter, is really this a high-level overview of the areas of work that public health is going to be focusing on over the next year. So to do this, we'll remind the board of, how do we come up with our areas of work? They really come from the core public health services, which is what we are required to do by the state statute. In addition to the priorities from our community health assessment and planning system process, that gives us our public health improvement plan and what those priorities are, which are shaping up to be climate change and access to care. You put those together, and those are the areas of work that we address as a department. So a little bit more of the details around the foundational public health services. The services are the subset in each public health program area that are foundational to building and maintaining healthy communities. And you can see they're in those great little icons across the top: communicable disease prevention, investigation and control, environmental public health, maternal, child, adolescent, and family health, chronic disease, injury prevention and behavioral health promotion, and linkage to access to and linkage with healthcare. You see down below, foundational public health capabilities. These are more of the cross-cutting capacities and expertise that we need to have within our department to support all of those foundational services and then any public health program that might happen. So you'll see that a lot of those foundational capabilities are happening throughout our department, throughout all of the different sections. This is just a little bit of a reminder about the CHAPS process, which gives us those public health priorities. And we really are wrapping up in finalizing our improvement plan. And we'll hopefully have more to share with you when that is finalized and how that fits into our areas of work. So before we turn this over to our different sections, to our different managers and section managers to talk about those specific areas of work, we just wanted to ground the conversation again in our mission, vision, values, and equity statement. So the mission, again, is to work with communities to promote health and prevent disease by protecting and enhancing environments, policies, and systems that support positive outcomes for everyone. Our vision, again, you'll see the word systems are in place to sustain a healthy and thriving community. Our values, our health and environment, inclusion and equity, and quality data and lived experiences. And then we also have an equity statement that I'll let you read that helps guide the work that we do in this area. And you'll notice that equity is one of those foundational capabilities that we are tasked with being competent in as a department. So I'll invite Larissa up to go through the planning, prevention, and partnerships areas of work.
Thank you. For those who don't remember who I am or don't know who I am, my name is Larissa Bonilla. I'm the Planning, Prevention, and Partnerships Manager. And I'm just going to give a quick overview of what work our department does and some of the different programs that you may or may not be familiar with. So kind of trying to frame this around the core public health services within the PPP department. We really focus on 3 different foundational public health services within chronic disease, behavioral health promotion, and injury prevention, as well as maternal, child, adolescent, and family health, which community health services helps us to meet those services, as well as access to and linkage with healthcare, which also includes mental health care. And so our programs that kind of cover those different services include the Tobacco Education and Prevention Partnership Program, or STEP, which is funded through CDPHE. Our Child Fatality Prevention System, also funded through CDPHE, and our Pitkin Area Co-Responders Team, or PACT, which is funded through 2 different grants, one from CDPHE and then one from the Behavioral Health Administration. And then lastly, our Vital Mental Health Services program, which is funded through the IGA with the county, Aspen Valley Hospital, Aspen School District, City of Aspen, and Town of Snowmass Village. So one of our first goals within the foundational service of chronic disease injury prevention and behavioral health promotion is really to reduce the incidence of preventable diseases, injuries, or other poor health outcomes across the entire lifespan. So some of the activities that we're continuing on this year that have carried over from last year or previous years is continuing to conduct any case-specific reviews of any child deaths that occur in Pitkin County. Last year, we did have 1 death that occurred. So this year we will be planning that case review for that. Promoting smoking cessation, preventing youth access to nicotine products, and also supporting school districts or youth serving organizations and other municipal governments and agencies with any policy work around this, resources, education, whatever that might entail. Continuing co-response with law enforcement on appropriate calls for service through our PACT program, and then distributing naloxone to community partners, which is a program we have funded through CDPHE. Some new activities that we're excited and looking forward to is the Pitkin County Tobacco Retail License, which Raleigh Bacharach provided a wonderful presentation at the previous board meeting. And so we will be bringing that proposal to the BOCC in March at a work session. A distribution of fentanyl test strips, which we talked about earlier. We're working on a contract with CDPHE to be able to obtain those and distribute those to the community. And then also, we talked about this earlier, but supporting Aspen School District with a standing order to distribute naloxone. And that's currently in the works. And then continuing to search for any other funding opportunities, as well as bringing the budget supplemental to support that communications, like health promotion type position.
Can I ask a quick question?
Yes.
Just thinking back to a previous report about the local schools having is it lower tobacco use incidents, but higher vaping, something like that. I don't want to get it wrong, but I thought I saw a report that said we had kind of a standout in the percentage of kids who were vaping. But it was lower for tobacco, higher for vaping. Is that correct? Higher than the state?
That's correct. I think it was for vaping. I don't have the exact percentage on me, but the percentage of, I don't know if it was high school or middle school students that are vaping was higher than the region average and state average.
Got it. And do we have a a strategy focused on local schools you could talk about?
Yeah, definitely. So there's kind of two-pronged right now. One is the tobacco retail license. I think that's one strategy we can utilize to help reduce access to those products. The second is Raleigh Backrack, who's our health promotion program administrator, is really working to build relationships with schools all throughout the valley to be able to serve as a resource, look at their tobacco control policies in the school, and be able to give resources to trusted individuals within the schools to help to reduce use as well, or students that are interested in quitting or anything like that. So we're trying both of those at this point in time.
Great, thank you.
All right, so within maternal, child, adolescent, family health, I will say this slide looks a little bit slim, and that's because we get very little funding for this specific area, maternal and child health. And also community health services does a lot of this work specifically. So our goal around this is related to maternal, adolescent, and child family health to increase health and well-being and reduce adverse health outcomes and advance health equity across the life course. So some ongoing activities is the services that Logan talked about earlier, continuing with that. And then also assisting with the implementation of our public health improvement plan that Jordana mentioned earlier, with specifically one of those areas of priority being access to care, which includes mental health care, behavioral health care. And lastly, within access to and linkage with healthcare, our goal here is to create a system of care that rapidly improves access to mental health services for Pickens County residents and workers and visitors. And so some of the ongoing things that are continuing this year is managing the Vital Mental Health Services IGA that provides funding for these services that are listed below: the school-based intensive wraparound integrated care and community-based mental health services. And some new activities is implementing what is known as the Mental Health Access Program. It's part of the Vital Mental Health Services IGA. It's just being specifically called the Mental Health Access Program as we try to create that coordinated care within that program. Jordana mentioned earlier also, we're currently interviewing for the mental health data analyst, and that position is to support the Mental Health Access Program and help to build the data infrastructure that we really need to be able to support individuals through the continuum of care and connect them with resources as needed. And with that, hopefully, we are creating and improving mental health data collection and management processes with that position and the Mental Health Access Program. And I think that was it. Any questions about the planning, prevention, partnerships, areas of work?
The only question I'd have, and I don't see questions from others, but my quick question would just be, I think I'll wait till we get to Dr. Levin's next presentation. You're up next, right? I'm just wondering if we're going to need to pivot at all. And it sounds as if I sent an article out, I don't know if the board saw it, just regarding the state doesn't seem to understand how they're going to handle the new rules regarding psychedelics. And I'm just wondering if you must be thinking about that too. I'm sure we'll hear from Dr. Levin. So anyway, that's how we segue to her. Dr. Kirk.
I'd like to put in a plug for the senior center. If I didn't see senior services mentioned, I've served on the senior council for 2 terms with term limits. So the senior center has a great location. It's near ABH and it's near your offices. And it's there are prevention specialists there, at least in the programs that can be put on, like Krista Fox will come over from ABH about balance control, et cetera, and people who've had balance or stroke problems. So since many of these services are reimbursable through Medicare, I think that would be a place to explore of having a regular kind of service through the senior center and to a monthly newsletter that goes out to seniors in the county. Seniors now are equal and exceeding the pediatric population. The 16, 17, 18% of the pediatric population, because of declining birth rates, is actually smaller. So don't forget seniors, and that includes me.
We won't forget you. Yes, thank you for bringing that up. I think that could be another partnership opportunity, ideally through that like communications, community engagement position. I think that's a huge need across the board in public health. So if we're able to get that budget supplemental approved and have some funding to continue with that position, I think that's another opportunity for partnership with CHS to be able to get out into the community and into those types of places.
Thank you. Thanks for bringing that up. Okay, I think we're good. Thanks.
Okay, thank you.
Good job. Glad to see you.
Good to see you too.
And so next, Dr. Levin is up. We'll wait
We're
for you to come back
gonna,
in.
we've got a couple more. We're gonna go through environmental health,
Oh,
disease
sorry, I
investigation,
skipped Kurt. Sorry, Kurt.
and then administration, and then we can talk about matching mushrooms.
Not just for seniors.
Hi, good afternoon, everybody. Kurt Dahl, I'm the environmental health manager for Pickens County. I'm going to go over both environmental health and disease investigation. Apologies for not being there. I have a couple of meetings after this, and then my wife has a concussion. And so I have the honor of taking the kids everywhere. They both have hockey practice, and I've got to be somehow back down here at 5. So being in person was a challenge today. I apologize for that. So environmental health, foundational service, environmental public health. We use environmental health and environmental public health interchangeably. Environmental health is really an older term. We say environmental public health because we're really connecting public health and the environment there. A lot of people, when they hear environmental health, they think I'm a county forestry department otherwise. So we've started to try to move forward with connecting that public health piece. And environmental public health is looking at anything that is related to the environment that is also related to public or community health. So those are programs that we're thinking about are air quality, water quality, zoonotic disease, which as a reminder, zoonotic disease, those are the diseases that are spread from animals to humans, things like rabies or West Nile virus or plague. So we're monitoring the environment to make sure that if that's out there, it's not spreading to humans, and then taking action if we see those conditions. Again, hazardous materials, we think about hazardous materials and trying to ensure they don't impact the public's health. We're also working now on public health climate change and mitigating and thinking about vulnerable populations and how hazards are going to be impacted by climate change, and then what populations are being impacted by that. And then we also work a lot with complaints, and we definitely have a complaint season from, say, the spring through sometime in the fall, where we spend a lot more time dealing with complaints, and those cross-cut across all of those different programs that we have. Next slide, please, Jordan. And you have to click through them, it's automated. So goals, tricky. Kim gave me that idea. So I'm going to run through the goals of each program. So the first goal we have is we use specific data at a community level to improve public health and assess our processes. So as an example, we have a PM10 program where we're looking at PM10 levels in the county. And then we utilize that to ensure that we're in compliance with the ambient air quality standards. And then we also use that to drive, are there other regulatory changes that we might need if we see problems with that? So we talk about in public health, we use data. That's one of our first goals when we're looking at all of our different programs. How do we utilize that to improve the health and make our processes better? Next one. Identify local, regional, and statewide assets. So we, as public health, assure for a number of services. We don't necessarily provide all of those services. So last meeting, we had the state health department here presenting on their retail food program. So that's an asset. They're doing that program. We're assuring that it's being done. Somebody else is doing it. The city has an environmental health department as well. So when we're working, anything within the city goes to them first, and then we partner with them for assistance. And then complaints is another great example where we're looking at assets. Right now, we had a complaint yesterday about a sewage leak out at the ABC. So we're working with Pickens County Building Department, Aspen Consolidated, and our code enforcement departments to look at who's, what is this, understanding if it's valid, and then whose responsibility is it to address. Sewage on the ground is a public health concern. It may mean that somebody else is addressing it, not us, and it's a jurisdictional piece. So again, identifying those assets. Next one. Protect, maintain, and improve air quality, water quality, food safety. These are goals around our inspection programs. When you think of environmental health, a lot of people will talk about it as being the regulatory or enforcement portion of public health, because a lot of what we do falls under regulations and rules and inspections. So again, that retail food program that the state does, they're doing inspections. Our septic program or OWTS program, we permit that and we do inspections. So a lot of that is assuring that we're protecting and then where we can improving those conditions. Next one. And again, this is about using community-specific data to assess the risk and mitigate risk with climate impacts. So again, Jordana mentioned earlier in our public health improvement plan, we've identified climate change. And so we're working with staff and other partners outside the agency, looking at public health's piece of how do we work on vulnerability and help to mitigate risks related to climate change. And that also crosses over with our EPR program. And then last one, again, we talked a little bit about zoonotic disease. We identify and mitigate zoonotic, vector-borne, airborne, waterborne threats to public health. And that program crosses over with our disease investigation. So next slide. So these are our current activities. It's not all inclusive. I don't want to go through every one of them, but these are the programs that we do on a regular basis. So OWTS program, again, that's our septic program. OWTS stands for On-Site Wastewater Treatment System. It's a water quality program because we're assuring that septic systems do not contaminate groundwater and make people sick. So it's a water quality piece. A lot of people don't get that connection. That's why we put a T in there for treatment. Again, we have a gray water program that we work on. We're working with the state to address that. We just got through Radon Action Month, where we were giving out free kits. We're continuing to give out free kits to test homes for radon, because we know that it's the second leading cause of cancer, lung cancer, in people in the state of Colorado. The other piece that I'll just talk about here, because I know I have a limited amount of time for both programs. We have the Smuggler Superfund site that falls under our hazardous materials program. And we administer that along with the partnership with the city to ensure that people who are working within that site are handling soils correctly. Next slide. Oh, these are automated too. So Lincoln, so the new activities for 2023, and some of this will go into 2024, but Lincoln Creek is up the Independence Pass. We're working with state and federal agencies on a sampling program to look at potential water contamination there. So we're waiting on the EPA. They have done some sampling. We're waiting on them to release the data to look at what's next, what are their issues, how do we address them. The state health department right now is changing a few of their regulations that impact us. That we have local regulations that then will be impacted that we'll have to rewrite. So we're working with them as they change their regulations, and then we'll have to change ours. Every few years, we have to update our fees for our services. Environmental health fees are set by the Board of Health. So we have a process where we'll go to the county commissioners to seek their approval first, and then we'll come to the Board of Health this year. But in looking at EH fees and changing our fees, we're also going to look at it with an equity lens, which isn't something common in environmental health. Most of the time when you have fees, they're really set at how to recover full program costs. And so we're asking that question, how do we look at that, and looking for examples. The PM10 program that I talked about a little bit earlier, that's a compliance program that expires this year. So we're going to be working with the city of Aspen and the state health department to submit a plan to the EPA on what do we do moving forward. We've been in compliance now, and we've been showing that we're maintaining that. But moving forward, we can't just drop this problem. And so we need to, or drop this program. So we need to come up with a plan on how we're going to move forward to assure again that we're not going to have a problem with particulate matter in the future. In the same realm, we have air quality regulations. Those can be specific around things like fireplaces, which relates to the PM10 program. Those haven't been updated in 10 years, so we need to update those. Last year, we received a lead grant from the State Health Department for testing of drinking water in schools and childcares to assist them with a new standard. And we're going to continue to work with that. We have several childcare centers that have expressed interest in having us come in and take their samples and submit them to the state for compliance. Last August, the state legislation adopted a new standard for schools and childcares for lead and copper. We're working with them to help provide that assurance. I think Jordana had mentioned this, but the state health department is also reorganizing their emergency preparedness and EPI programs, the regional programs that we work with. Again, some of those assets that we have when we have either like a wildfire emergency and we have an emergency preparedness person who supports us. The state is now reorganizing that and looking at how they can more effectively administer those programs. And we're working with them, one, to make sure that they're doing what we need and understanding what our needs are, and then for us to understand what it is we're going to have to supply. We've talked about this a little bit. There will be a time when Tom Dunlap, who's our Superfund site administrator, will decide to retire, and he'll hand those reins off to Brian and me, and so we'll transition that program over to regular staff. And then the last piece, we've already talked a little bit about the climate change piece in the FIP, and working with our staff and partners on public health's role in addressing climate change in the county. And I believe that's the last one there. Oh no, we have EPR as well in this one. So the other piece that we put under environmental health is emergency preparedness. Now, this is a foundational capability, not a service, because it's cross-cutting over all the departments in public health. But it lives in the staff member sits under environmental health. So again, this is to respond to public health emergencies like the pandemic, like wildfire smoke, where we're educating the public on wildfire smoke. So really, we're looking at responding and leading public health emergencies. ESF8 stands for Emergency Services Function. Number 8 is the Public Health and Medical Services branch. Really, that's supporting the Emergency Operations Center where there's an emergency. That's supporting the resources needed for the emergency and really helping Valerie in an Emergency Operations Center. We lead that program in the county. The other piece that we do is provide training for all of our staff across public health preparedness. An example of that, one of the new activities that we're going to do that's a crossover again with our zoonotic disease, is we're working with local partners on a rabies tabletop. So it's a zoonotic disease piece under environmental health, but it's also, if you're really dealing with an outbreak of rabies, then it becomes an emergency preparedness piece too. We're working on some additional radio training for staff. And then as part of the FIP, as we talked about with the public health climate change, part of that's looking at the all hazard plan that the county has set forward and is in the process of adopting. And we will look at that as a department and work with Valerie, who's our emergency manager, to think about how climate change might impact those hazards and then what populations those hazards might have a greater impact on and what vulnerable populations. Next slide. All right, and then disease investigation. And I've got a couple of minutes. I got to fly through this. So again, this is a foundational service, communicable disease investigation, prevention, and control. Pretty self-explanatory. This is our part of our department that we're investigating diseases. We're taking measures to prevent the spread of disease. The COVID-19 response team falls under this piece. And as well as, again, we have that crossover with environmental health with zoonotic disease. Next slide. Go ahead and click. There are 5 goals, Jordana. So again, providing timely communications to the public and to our partners on communicable disease issues within the community. The biggest piece of this is what we call our HAN, which is a health alert network. that we redistribute to our local providers and partners within the community. And those are communications that come from the state or the federal government around things like disease outbreaks, food recalls, uses of medications with COVID-19 and their approvals. So this is all information that then gets passed from the feds to the state and then down to locals, and then we pass that out to all of our providers to help keep that flow of communication going. Next goal, we identify assets again, just like environmental health. Great example, Logan talked about the contracts we have with CHS for TB and immunizations. So we're not necessarily providing, but we're assuring that others are providing services into the community, and those contracts are a great example of that. Then we're investigating the outbreaks, reports of disease, and unusual trends. Promote and provide immunization is one of the goals. Again, our contract with CHS was really where we see that efforts put out. And then we coordinate with other departments and foundational capabilities. Again, those crossovers with environmental health are great examples in those goals of zoonotic disease. And in cases of emergency preparedness like the pandemic, there's a crossover there. Next slide.
Thanks, Kurt. I think just before you keep talking, I just wanted to point out to the board, when we came and talked about our foundational capabilities and services, how well we were doing, where we needed more capacity, that how we tried to organize the presentation today, all of our goals are really tied back to those foundational services and capabilities. So just as you're hearing these are we're trying to help answer some of those questions of what are all of these things and how well are we doing them and to what degree. Thanks, Kurt.
Thanks, Jordana. So just the last slide here. Again, our ongoing activities, Health Alert Network, disease investigation. We have our contracts with CHS for tuberculosis and immunization, and then our COVID-19 response. In our new activities, what we're looking at this coming year, again, we've talked a little bit about assisting CDPHE as they reorganize the regional emergency preparedness and EPI teams. Jordana talked a little bit about securing funding for to extend the communications position, and that's pending county commissioners' approval. So we're really looking at the grants and the funding that we can have in place to make sure that we can continue that position. We're looking at, we know that the COVID-19 team will be leaving us, their term limited staff. We do have a new epidemiologist, that position that's been approved that will continue on. But as we lose those staff, either to other opportunities or when they come to the end of the term, thinking through that transition plan of going to one staff member leading primarily with then another half staff and other staff to support. How do we assure we're providing the services we still need to provide in those goals, as well as coming up with a plan for if we see a surge, how are we then addressing that surge? Who are we pulling in to help with that per staff member to address outbreaks, things like that. And with all of that, are there any questions?
You have any questions on your panel there?
I don't see anybody's hand up here.
No questions.
Kurt, Linda Vieira, hi.
Hi.
I was wondering who actually identifies PFAS in our streams and waters?
So the state health department is working with locals for water systems. The state has funding from the EPA to do the testing, and then we've promoted that a few times with local providers just to see. I know we've had a few people take on and actually do the testing, but if you look at the state map, I think when I looked the other day, there were 2. But there is funding out there if you're a water provider or even a private well owner to have that tested. It's a great question. It's an emerging issue.
Do we know what the contamination is in Lincoln Creek?
The Lincoln Creek contamination, could you talk a little bit about that? I'm not sure people know
Yeah.
briefly what happened up there and what do you know?
So Lincoln Creek is, like I said, it's up Independence Pass. It is historically a mining area that's above the creek, and so we have a number of old mines that we have concerns about heavy metals that potentially could be infiltrating the stream. And so the goal right now, the EPA was contacted not last fall, but fall of 2021 with concerns over a fish kill in Grizzly Reservoir, which is fed by Lincoln Creek. So in doing that investigation, they decided that they wanted to at least do some testing to see if we could quantify if there is a problem, and if there is, what is it? So right now we're thinking that, if you look at Lincoln Creek, we have different parts of the creek that have different sediment colors, orange above the reservoir, and then this whitish precipitate below, which are probably things like iron and aluminum. But there are other questions about, are there issues with copper, lead, or not lead, copper, zinc, which are all health concerns at lower levels. So that sampling is really looking at quantifying that so that we can then determine if there are problems. Is it a human health problem? Is it an aquatic life problem? This is a drinking water source as well for Colorado Springs. So are there any concerns there? Once we have the samples back this year, or the data from the samples back this year, then we'll assess any issues and then just talk about next steps and what might occur then after that, if there needs to be any next steps.
Kurt, can you talk about the number of players that are around that
Yeah.
table?
Yeah.
That it's
So-
not just us.
Yeah, so it's a number of people. So Colorado Parks and Wildlife is the one who identified this. Division of Mining and Reclamation, which is the state health department, or it's not state health department, but a state department. The state health department, water quality control, the EPA, the Forest Service, my department, Roaring Fork Conservancy, Twin Lakes Canal Company, which is who owns Grizzly Reservoir, and then the tunnel that goes underneath to fill Twin Lakes. I feel like I'm forgetting one, but there's 8 agencies right there that are all working together to try to assess this and then figure out how we're going to address it if there are issues.
And I think it came from after disturbance up at the dam reservoir or a portal up above upstream. I think there was some sort of mechanical disturbance with something being moved around or silt being cleaned out or something which caused this flow, which changed the precipitate on the rocks for miles downstream was noticed. And I think that's how it first came up. And there was a question about whether or not marine life, fish life was being affected. So I guess we're going to wait to hear on that.
And is that water that's tunneled to the Front Range?
Yeah.
Yes, there's a tunnel that goes under the mountain that fills up Twin Lakes Reservoir, and they have senior water rights to take that water over. So, and there wasn't a fish kill that we knew about this year. We think somebody repeated the fish kill from 2021 information mistakenly. But there seems to have also been some type of event that did carry some of the sediment downstream further that was also part of the cause of concern. And we did not know that the EPA, in Pickens County and the Environmental Health Department didn't know that they were doing this water sampling until this last fall. And so we've now inserted ourselves into this conversation with the EPA. And they've been good partners, but that's just not typically their standard to go out and reach out to all the local agencies when they go into somewhere to do sampling to assess a situation. So
Thanks for that. Other questions? Not seeing any. We're going to keep moving. We're right on schedule, ahead of schedule.
All right, to share our last section of our department in administration. We really cover a lot of the foundational public health capabilities, assessment and planning, communications, policy development and support, organizational competencies, and health equity and social determinants of health. The goals, we've got 5 goals around those foundational capabilities. For assessment and planning, it's to assure assessment and planning capabilities within the department in order to ensure community health needs are understood and addressed. So the work that we're doing around our public health improvement plan and those resulting priorities around climate change and access to care fall under that goal. Around communications, the goal is really around being a trusted source of clear, accurate, timely information. And so some major rocks, some big goals we've got in that area are around transitioning our COVID website, newsletter, and social media into more of this ongoing public health response and not just focused on COVID-19. As well as we have some topics that we'll be pushing out into the community on a quarterly basis around tobacco, radon, National Public Health Week, opioids, and respiratory illness. So now that we're back to our normal cadence, we'll be picking some different community topics for campaigns throughout the year. Policy development and support is really to do some training for staff and board, and then to potentially select some policy priorities with the direction from the board. So this is some new areas for us to explore and try to get out ahead of what the policy concerns would be and how we can proactively address those. Organizational competencies is really around our department being accountable and transparent so that the public can understand the value that they get from the investments that they make into the public health system. So currently we're going to need to rehire our deputy director and grow that admin capacity. We have a number of projects around quality improvement around some of our financial and contracting processes. And then to increase the transparency, there's a new application called OpenGov that the county is using that allows us to show the funds that are being spent in various areas. That can be very helpful both internally and then also to externally to be transparent. So that's a project we've got on the docket for this year. Finally, we have a health equity and social determinants of health as a major goal to do some training around, to continue to build some community engagement and partnerships. And then also each staff member has some personal equity goals that relate to their work and their equity training on an individual level that they have entered into their individual development plans. And there's funding associated with individual development plans for everyone throughout the agency. So those are the high level areas of work that we have planned for our admin team as we go into 2023. We're already into 2023. And so Greg, as we move forward and talk about the Prop 122 and some of that legislation, how you posed, with this legislation coming up, might this be something that we need to shift and change? And I think, part of the reason we want to be able to share our work plans and our high level goals with the board for the year is that knowing that if another big project does come up, we might need to take something else off the table that we had planned for the year. So just letting the board know that, this is the opportunity to learn about the plans for the year. And that if something else comes up, we might be coming back and saying, hey, we might need to shift some of those priorities to address something that's emerging.
Great, thank you. I'm sure we'll think of some things. Thank you for that. With that, we're going to move over to Dr. Levin, back on deck. The main attraction.
I noticed that this was put at the end of the schedule, so to keep everyone awake, I have some samples. Okay.
We're going to plow right through. I'm sorry I didn't take a break here, but I never
Here's
did.
mine.
No breaks.
Oh, yeah.
And I think I actually get the first slide here, so I
First
get
slide,
to
yeah.
keep talking. So back in November, Prop 122 was on the ballot. This decriminalized and created a regulated access program for certain psychedelic plants and fungi It passed by a margin of 53% to 46%. Since this passage, there hasn't been much new information regarding the implementation. So what we're sharing with you today is what we know, what we've been able to gather. The first impact of the law went into effect in January on the 4th, when criminal penalties for the possession of psilocybin containing mushrooms and other psychedelic drugs for individuals over 21 were removed from state and local laws. Additionally, growing mushrooms and certain other plants or fungi are allowed as long as it meets certain criteria. So it has to be done in a private residence, and the products are not available to individuals under 21, and that they can't be sold. So no payment can be made. So unlike what we saw with the legalization and commercial sale of marijuana, this is very different. Prop 122 doesn't allow for the retail sale of psychedelics, but it does create the pathway for the licensure and regulation of healing centers, which is along the lines of the article that Greg sent out the other day, where in the legislation, it was designated that DORA is charged with drafting the rules that will govern these centers and their facilitators. The license applications are slated to schedule in September 2024. With that, that's kind of what we know at that high level. I'll just pause to see if I can clarify anything there.
So what does it mean for our area?
It means that this, that healings, that right now, what does it mean? People can grow these psychedelic plants and fungi for their own personal use. It is no longer in our state or local laws that it has been removed, that it's not a criminal charge anymore. That has been removed from the law as of the 4th of February. And then what it means is moving forward, there will be some opportunities for locals to regulate at the local level, pieces around, you can't disallow it at the local level, but you can say where these centers might be able to operate. You can say the times, there are certain pieces that you can regulate at the local level. But a lot of that is still forthcoming because we haven't gotten any additional information, but that's what we're expecting.
And you said there was a date that you could start taking applications for?
In this legislation, it's slated it for September 2024. But right now, they're still trying to figure out at DORA.
Applications for the healing centers.
Applications for the healing centers. But DORA is still really trying to figure out who's gonna lead, how they're going to lead this effort, because they've been.
Yeah, very different from marijuana. So there are not going to be retail stores that open. It's decriminalized to possess it. So you can possess it, you can grow it, you cannot sell it.
Right.
So it's not going to be packaged and sold and have any issues about that. But
And you
the
have to
plan is that it's going to be more of a natural medicine type of kind of construct where there's going to be these healing centers. So it's kind of a medicinal healing centers, and the task force at the state level is just being assembled. I think it's just been chosen. There's 15 people. There were over 200 applications for it. They chose 15, and they're just in the very beginning stages of all of this conversation. So I think, yeah, my take home from this was there's very little known and there's very huge change. And, you know, the policy and the law has just jumped ahead of any kind, the law has just jumped ahead of any kind of policy that's in place now. There's nothing in place. It's going to take maybe a couple years.
And we're only the second state.
Yeah, so Oregon was the first state, and there's no lessons from Oregon yet because they are just basically now starting their first healing centers. So we don't know, or what, I don't know if they call it healing centers. So we don't have any lessons to share from Oregon as of now. All this is new. It's a brave new world.
It makes you wonder how many healing centers we're going to have locally. You know, one on every corner or every other corner, or.
Yeah, it's all very concerning.
And those may be some of the opportunities for local regulation.
Right, number of, or location, or district, or.
Yeah.
ways of doing that.
So I'll try to go through my slides pretty quickly. I think the opportunity for conversation here is great. But again, we're at such the beginning phases that it's really hard to plan anything right now and know what's going to happen. But I thought I'd start with this photo that some of you in the room may be more familiar with than others. And my big disclaimer is that this talk comes from no personal experience. So starting with that, this is a huge, kind of a huge complex picture that we were just talking about in terms of Colorado has just been completely thrown into a situation where there's a Schedule I drug, which is the highest restricted drug that's suddenly available to the masses. And how do you make this in a safe way? So as a physician, I think about my Hippocratic Oath and do no harm. And this entire situation, I'm kind of looking at as like, how do you do more good than harm here? And there is a huge I mean, I really knew nothing about this. I had to start talking to people. I've made some great connections. I have a connection with Dora now at the state, just through conversations and talking to people about this, just trying to learn myself because I really didn't know anything. And I think my overall take is there's a great potential for good and for helping a certain subset of people in a very safe way. And there is also an enormous potential for harm if it's out in a way that in masses and done in uncontrolled environments and in the hands of the wrong people, and especially children. And we've learned that lesson from marijuana. That the teen use of marijuana has risen significantly since the passage. And that's one of my main concerns is keeping it out of the hands of children and the education component of that. So moving on. So this picture is a photo of magic mushrooms, which have psilocybin in them. And psilocybin is the primary psychoactive ingredient in magic mushrooms. Now, what I learned is that there's over 100 species of these mushrooms that make psilocybin. So immediately you think about dosing and concentrations and how do you control all that and how do you know what you're taking? How do these facilities know what they're giving people? A lot of and I'll talk about a couple of clinical trials that have been done, but the clinical trials use a synthetic psilocybin. So they're very controlled doses. They know exactly what they're giving patients in trials. None of these centers are going to be synthetic. It's all going to be natural. So the synthetic psilocybin is only available for clinical trials. And so that I think dosing is going to be a big issue and potential for harm. And a lot of control is going to be needed for that. So next slide, because I'm a geek, I have to show that this is a chemical. So this is psilocybin. You ingest it, your liver metabolizes it into a compound called psilocin. And that is the active compound. And what this does, that's what causes the kind of hallucinogenic, mind altering, distorting effects in your brain. And so psilocin turns out that it changes the neurotransmitters in your brain. So it actually changes brain chemistry. If we go to the next slide, another geeky slide, I had to show a transection of the brain here. So it does a lot that's unknown and it does some that's actually known. One thing that we know that psilocin does is that it affects the serotonin pathways. The serotonin pathways are throughout the entire brain. And so what it does is it's an agonist for one of the receptors, which means it acts like serotonin in your brain. And the serotonin is a neurotransmitter. So it's a chemical that transmits a message from one neuron to the next. So it will increase transmission and change the chemistry of the brain and the way that nerves are transmitting signals. And they are throughout your entire brain. Serotonin is responsible for mood and, so why it is actually the neurotransmitter that's targeted for a lot of antidepressant medications. So if you've ever heard of SSRIs, selective serotonin reuptake inhibitors, those are Prozac, Paxil, Lexapro, Celexa, any of these drugs that are so common right now. So they're using serotonin as well. Another thing that psilocin or psilocybin does to the brain is it increases communication between all these different sections. So the prefrontal cortex, the visual cortex for hallucinations, the amygdala and the limbic system inside for emotions and memory, and it changes the neuroplasticity. And so when you go on this huge trip, or if you use a large dose of psilocybin, it can actually, what some people are saying, reboot the way your brain interacts in all of these different areas. And that's just the beginning. And I think there's so many unknowns of exactly what it does to your brain. And I think, so, you know, from a physician's point of view, we see people are taking SSRIs, taking all kinds of antidepressants. You add this medication, call it a medication, on top of it. There's going to be interactions. There's going to be additive effects. There's dangers involved with that. But that's my understanding of a little bit of how it works in the brain. The next slide. And my take home point that all of this will need to be done in a very controlled, safe manner with skilled practitioners in each of these centers. And I think locally we may have some control or I don't know, some policy about who these people are who are running the centers and what kind of background and skills that they have. So I think this is interesting. I learned a lot looking into actually what medical conditions could this be used for. One of the main ones is treatment-resistant major depression, which is basically almost a epidemic, really. There's many people who are treated with depression from the tools that we have. So counseling, medication, all kinds of cognitive behavioral therapy, EMDR, there's a lot of things that can be done. And there's people that are resistant to all the treatments. And this could actually really be life-changing for these people. So a very specific subset. PTSD is post-traumatic stress disorder. Veterans, people who have been through very traumatic situations, this could be potentially life-changing. Substance addiction, substance use disorder and addictions of all different types, from alcohol to all different types of addiction, generalized anxiety disorder. And then what's really interesting, and they're doing research on this at Anschutz Medical Center in Denver, on late stage cancer and terminal illnesses and people that are in that situation. And they're kind of emotional anxiety and distress of knowing that they live with a diagnosis like that. OCD, anorexia, smoking cessation, chronic pain, and probably more. So I think, again, its potential for good is enormous, and in very, very specific people in specific controlled environments. Next one. This I'll just go over briefly, quick history. I don't know if you all know what a Schedule I controlled substance even is. In 1970s, kind of in the response to the psychedelics being used in the 60s and the hippie counterculture movement, the DEA responded and created the Controlled Substance Act. And there's 5 different levels. Schedule I is the highest of the control, and that's what psilocybin is in currently on the federal level. Other examples, heroin, MDMA is ecstasy, GHB is the date rape drug. When you take it, you become unconscious. So all of these are kind of in that Schedule I drug. Sorry, I put 2 S's up there. Schedule II, for example, is OxyContin, and then down to Schedule V. So this drug has just gone from a Schedule I, the most restrictive one, to open to the masses. Highly concerning. So over the past, so what happened in 1970 when the DEA did this, they formed this, it really put an end to all the research being done because it didn't really allow research. However, in the past 20 years, there's now more research that started up, and it's this body of research in the past 20 years that is really leading to show that this is beneficial in certain ways. So UCLA in 2004 looked at advanced stage cancer patients. Johns Hopkins now has this huge center where a ton of research is being done, Center for Psychedelic and Consciousness Research. And again, UC Anschutz, and it's all over, there's centers all over the United States now that are doing research. Again, all of this research is with, my understanding is it's with synthetic psilocybin, so very controlled amount of doses. The overall take of looking at this research is that we really need a lot more high quality studies. The sample sizes are really small and the follow-up is really short. I'm just going to go through a couple here. This might be a little boring, but I'll just go quickly. Nobody likes to look at studies. The next one. So this one, and I chose one out of the New England Journal of Medicine. It was in 2022, I think even November, single dose psilocybin for treatment-resistant episode of major depression. So 79 participants, they were given 3 different doses, 25 milligrams, 10 milligrams, and 1 milligram, and they compared that one dose to 3 weeks later. And they showed that the 25 milligram dose reduced depression scores significantly, but they did have adverse effects. So this is also has side effects. 77% of people had headache, nausea, and dizziness, and then suicide ideation, behavior or self-injury was in all groups as well. And so if you look at that green bar coming down the top, that shows that the 25 milligram or the highest dose gave the greatest decrease in depression. And then the adverse effects, the green line, which is the 25 milligram dose. So the one that was most effective also had the most adverse effects. The next one. This one was in the Journal of Psychopharmacology, 27 participants, so really not that many people. History of long-term depression. They got 2 doses. So they got a dose at time 0 and then at 2 weeks, and they got 20 milligrams and a 30 milligram dose. And this was nice because it looked up to 12 months and they show that there was improvement that continued. You know, do just 2 doses 2 weeks apart, you know, does that not last, or does it last? Like, this is all so experimental right now, not even knowing like how many doses, how many, and what the effects are. So you can see after even 1 week, it went down, the depression scores went down, and they kind of stayed down up to 12 months, which was pretty impressive. The next one. This is the last one I'll show, another New England Journal. And so 59 adults, again, not a lot of people. They compared psilocybin to escitalopram, which is Lexapro, very common antidepressant, and said, hey, does one act better than the other in the same situation? And they used this 25 milligram dose again. And they found that there was no significant difference. And they looked at it 3 weeks apart. What did they?
This is 3 weeks apart.
Yeah.
This is daily.
So they did not find a significant difference. And they also found that the adverse effects were pretty similar above the 2. So psilocybin is not more harmful, but it maybe not adding anything else to what we already have. So lots of different trials, small sample sizes, not long follow-up, and a lot more that need to be done. Next slide. So again, the way I'm looking at this is, you know, potential for harm, potential for good. This one is the harm slide. The next one will be the good slide. But I think these are just issues that came up for me as I spoke to these different people, and I'll give thanks to everyone that I was able to talk to and get information from. But so the potential for harm and things that we'll probably want to talk about locally so that we make a safe environment locally when this happens, is an uncontrolled environment in these healing centers. So who are the practitioners? What are their skills? What are the doses? And, you know, is this being done in a safe way? My understanding is in these healing centers, the doses are going to be very large. So they're in for like a huge 8-hour type of trip. And doing this like rebooting of the brain. And these are for people with really, you know, treatment resistant depression. So we want to make it safe. So potential for harm is an uncontrolled environment in these healing centers. Next, oh, that's fine. Yeah. So any type of damaging or traumatizing experience. If someone has a bad trip and that lasts with them as a traumatizing experience, that's a potential for harm. My big thing is access, that children gaining access to this, and a lot of education. And I think local education will need to be done to avoid this. Obviously there's no research project research that I know about on children and their developing brain and long-term cognitive effects of giving children psilocybin. And is this a gateway drug for kids, you know, as marijuana is as well? And the lessons from marijuana, and I think kids got hit hard for legalization of marijuana in our state. The other potential for harm is someone takes a big trip and then they do something dangerous. You know, I don't know that this is going to happen a lot, but if it does, it could be potentially fatal. So someone who drives, someone who does other types of activities that put them or others at risk, psychotic episodes where people jump from buildings because they have taken a dose that's too big, or they have underlying psychiatric disease that puts them into a psychotic state. So side effects. I didn't mention this. I can just quickly, there's something called serotonin syndrome that we all know. I've seen it in the ER. It's not very common, but it's when these serotonergic drugs, and there's a lot of them out there that people are using, where there's too much of it in one person, and it puts you into this like syndrome that can potentially be fatal and end with seizures and death. And that a lot of it doesn't end in death, but it is it's highly dangerous when it happens. So we have an unknown dose of psilocybin on top of someone who's taking multiple SSRIs, and what's going to happen? I mean, are they going to go into serotonin syndrome? Will it put them, in a really dangerous situation? The other thing is a lot of practitioners may say, okay, you need to stop your SSRI because this might interact. So we need you to be off of it before we give you this. Stopping an SSRI is dangerous. It needs to be done over a very long period of time. If you abruptly stop it, there's a withdrawal syndrome. So all of this just needs to be in conversation. And I think about this as, natural medicine board and natural medicine centers. And so it's under this umbrella of medicine, but yet who are these practitioners going to be? And they're, as far as I know, they're not going to be physicians, but all of this needs to be understood before somebody goes under a high dose. Okay, next one. Again, patients who have underlying psychiatric illness such as schizophrenia, bipolar, it could put people into a psychotic state and make it very harmful. Accidental overdosing, again, unknown potency, quality. Maybe it'll end up being contaminated or laced. Who knows what's exactly and what. And then my concern, at some point, industry interests, I always get worried about big business wanting to come in and market. We saw that with marijuana. We saw it with vaping flavors. I mean, it clearly is an industry that could be marketed and could be potentially big business. Another potential for harm. And then my concern is recreational use ends up being greater than medicinal use. I mean, with marijuana, the medicinal use of marijuana was like very quickly overtaken in terms of the recreational use. And that probably will happen again here. And I think that has more potential for harm than good. And is there one more on this, or is that it? And then enforcement, which I think is difficult. Okay, next slide. Potential for good. I think there's enormous potential for good. There's only 4, and I had to add one more. There's bigger font. But the categories contain a lot. I really do think there's a potential for good. I just think it needs to be done very carefully. Very specific patients, veterans, people with end stage cancer and other diagnoses. It's generally a good safety profile. It's just the interactions with other medicines. I'd like to think and hope that it ends up being another tool in the toolbox for mental health practitioners, that we're not gonna jump to this, that we're still gonna kind of use everything. And then if nothing else works, let's try this. So another tool. And just 2 more slides. So these are kind of my big themes that walking away from this, that food for thought is education. And it's a very complex situation, and it's really important to look at the complexity of it rather than kind of media driven simplistic views. Children and access to children, making it a controlled, safe environment in these centers. The safety of medication, more science driven studies. Don't let policy get ahead of science. And then enforcement. So we know that DORA, and I did read that article, thank you. So DORA is the agency that does my medical license. That's what DORA does. And they are in an unknown territory here. And they have a lot of work to do. And I think they are a little bit daunted by this. And I spoke with somebody from DORA this morning about it. And yeah, it's nothing that they've ever done before. So this is something new. I know it's going to take a little while to roll out. But these are all things to think about. And then lastly, I think what we can do locally is really encourage communication and conversations and include all of these sectors of our community in these conversations to make it safe and educate everybody so that we're prepared locally as well. And then I think I have one more slide. Oh yeah, this is what I want to thank all of these people. So Krista Hazel, who's on. Thank you for helping me start this conversation. This is Christina King, who was on the Board of Health. She helped me really think through in terms of mental health practitioners viewpoint. There is a Dr. Tamara Stoner at the Satori Integrative Medicine in Glenwood Springs who helped me enormously. She's an anesthesiologist who does ketamine clinics, and her viewpoint and understanding of dosing and all of that was really important. Martha Hamill, I spoke to this morning from the Aspen Psychedelic Resource Center. She just made a nonprofit from the Right to Heal movement that she was part of. So now there's this nonprofit that she's starting locally, and she is really interested in having these conversations and bringing these conversations to the table and looking at all sides. So I really appreciated that. And Sam Barami is my contact at Dora now, who just started the job, and he is overseeing the whole board. So that I thought that was a great conversation this morning, just learning about what they're up against. And Skippy Mesereau and City Council helped connect me with many of these people. It was an investigative journey, and I thank you for starting it off, Greg, because I think you requested it from the last Board of Health.
Right, thank you. That brings up a lot of questions. I'm sure others probably have some. Thanks for the presentation. I guess we're gonna wait and see what happens at Dora, right?
Well, I think they're, almost this entire year will be putting together some kind of a plan.
Right, I'm just wondering do you see a need for the Board of Health or and Public Health to actually come up with some prophylactic, proposals for when whatever the Dora plan comes along? Are we going to want to have a local perspective on this?
I think it's good to have conversations. I personally don't know that I think the state needs to make the first move and that's my understanding, and kind of make the format of how it's going to happen and roll out. But just the understanding of what's happening and what we can do locally to increase education on it, especially kids.
Yeah, it's fascinating. There are 100+ varieties of psilocybin mushrooms, and I'm assuming some of those are probably quite toxic with other chemicals in them.
Oh yeah, psilocybin is just it's like the main psychoactive ingredient, but there's most likely many others that we don't understand as well. People growing them, you can grow them, you can give it to others, you can take it. That's legal in the state, but not federally. So what does all this mean?
Right. Thank you for that. Wow. Comments, questions?
Very nice presentation. I've sort of been involved with mushrooms long-term because I went from the Rocky Mountain Poison Center to Dallas and to start the Poison Center at UT Southwestern, and have been involved in mushrooms in general during that time, in which psychedelic mushrooms would occasionally come up. And in that past history, there is a mushroom festival in Telluride every year in August called the Telluride Mushroom Festival that has been doing this kind of thing sort of within tolerance of the local authorities, because there are the Ute Indians involved, I think, as some of the advisors and so forth. But I think, as you pointed out, there's a certain amount of caution that is needed here because of people being on serotonin-related drugs. If you look at, I've looked at studies like you've cited, there are a certain number of people that have bad trips where they will go around and damage the property that they're in or hurt themselves, and there have been suicide reported. So usually when a person gives the drug, they're doing it in a supervised environment where they're there for 6 or 8 hours and there's someone watching you. So if you begin to do things where you can injure yourself or others, that you're sort of under control. Now, with Colorado and Oregon being one of the 2 states that are doing this, this is sort of going back into the cannabis days where people will flock to those states to get treatment. And so in Aspen, I think we need to anticipate that there will be tourists coming here that will be psilocybin tourists.
Absolutely.
And consider how you're going to deal with it.
Great point. Yeah, and those centers, like you said, these are long, 6-8 hour episodes, and the safety of what happens inside those centers is going to be essential.
For those who are interested, the Telluride Mushroom Festival is August 16th to the 20th, 2023. And all are welcome. You can go online to their website and buy a pass.
Go do research.
Well, I mean, somebody should go down there and check it out, I think. Just to, you know, it'd be interesting to know, what are we being cautious for the right reasons and in the right places? I think it'd be good to go and see what.
Well, the focus of the Telluride Mushroom Festival is really gathering mushroom, like in understanding mushrooms, non-psychogenic,
It's not all, but.
not psychedelic mushrooms,
not
but
all
this
about
is like a added, side
And
thing that
August is
happens.
the month.
Right,
Yeah.
August is mushroom month. Well, we all love collecting mushrooms for cuisine here, and usually you try to get to know the ones. If you're suspicious at all about a mushroom, you don't eat it. But we do hear about mushroom poisoning occasionally, and sometimes I guess it's fatal, other times it's just really miserable. And so this brings up so many questions, so thank you for that. I'm not advocating people buying a ticket to the Mushroom Festival, but on the other hand, it'd be nice to know what their experience has been, what the local doctors in Telluride have observed.
And from your comment, I just wanted to add, this is just the natural healing from centuries of Native Americans and Mesoamerica and just people that have used these substances through thousands of years. And this is where we are today with it. And so I think the board, the Natural Medicine Board, Advisory Board that's just been formed will have representatives from those groups as well.
Great. Thanks for that. I'm going to keep us moving here. If any questions, throw your questions out if you have any. Thank you, Dr. Levin. That was quite thorough. This is round robin, which I'm going to give it a couple of minutes. We've already been talking. If anyone has a topic they want to bring up for the board, this would be a good time. Any questions or concerns? But if I don't see anybody, everybody's sitting on their hands here, then we can talk about the next. Aha, Linda has got something. Thank you.
I think it's for Jordana or Carly about the high efficiency air filter portable air cleansers. Are they offered in the preschools as well? But ooh, I can't hear you, Jordana. Okay, better.
That's better. Where's the mic? I think it's going,
The
it's just the owl. So how about now?
Yep, good.
Okay. The program is offered to any K through 12 school, private or public. If there's a child care that's associated with a K through 12 school, they could be considered and included. But if it's just a standalone private child care center, unfortunately, that program does not apply for them. So I have sent it out to Aspen School District, Aspen Country Day, as well as the community school here locally. Those are our K through 12 schools in Pitkin, to see if they would be interested in applying. And the program provides HEPA filters for the entire building, with maintenance for up to 2 years, and then filter replacement and maintenance is the responsibility of the school district.
Okay, great. Thank you. If nothing else, I'm going to go to our the next meeting is the Board of Health Retreat, May 11th. Anything you want to tell us about that? It's 11 a.m. to 4 p.m., which probably means lunch is included.
Lunch, yes. Let me know if you've any lunch concerns or preferences. We'll be drafting out the agenda, probably bringing in an outside facilitator. We'll probably be looking at an EDI component, some policy work. I think we've got John Peacock reserved to come and talk with us for understanding, you know, how boards work and function. But if there are other topics of concern or areas you'd like to focus in on, please feel free to reach out to Greg, Krista, or myself. And then just reiterating that the plan for that is to be fully in person. We have the library community room scheduled for the time being. So we're not planning on having a virtual option for that long of a meeting time together.
That's the Dunaway room next door.
Yes.
Yeah, that's community. Yeah, okay, great. Okay, that's great. I think that's the end of our business for the day, and I'm gonna look for a motion to adjourn. So whether or not we need one. Kurt, we got a first, we got a second from John. All in favor? Nay. Oh, we have a nay there. No, I'm guessing no. Thank you all for coming. Stay in touch. Appreciate it. Goodbye. We can log off. We're done. Thank you.
Thanks,
all.
everyone.
Thanks. And we're 5 minutes ahead of schedule. How about that?
Amazing.